Welcome back to the third lecture preview for the cardiovascular section. This lecture will be dealing with action potentials as well as discussing the Frank-Starling curve. Um, Introduce the topic of action potentials, cardiac action potentials to you in class, and I told you not to worry, just to have a basic understanding, become familiar with the terms that we were discussing. So here we'll dive into a little bit more about the cardiac action potential, tell you some important points, and I will tell you what to know for the exam. To understand the cardiac action potential, you need to first understand that this is discussing the ventricular action potential. So, initial depolarization coming in, you have this electrical response, and in return, the ventricles and atria are contracting. In order to understand this, we'll go back and just kind of touch base about the neuronal action potential, which you covered in um, Anatomy and Physiology 1. If you will remember, there's going to be some terms here that we'll talk about that will seem familiar. It's important to know that every neuron has a something called a resting membrane potential, and this is always usually negative. Within the neuron, it's around negative 70 millivolts, and um, depending on the amount of ions that's present inside and outside of the cell, this will determine the um, how negative the resting membrane potential is. So we know that we deal with sodium and potassium ions. So usually in the extracellular fluid, you have sodium ions that are present, and then within the intracellular fluid, you have potassium ions, which are going to maintain the negative resting membrane potential. You know that initially um, during excitability period known as depolarization, you have something called a threshold, which is the amount of ions that have to first enter in to make the resting membrane potential less negative and more positive. Once it becomes more positive, something called depolarization can happen and the action potential can fire. So we will eventually reach a period of time whenever repolarization happens. And during repolarization, this will the ions, such as the sodium ions, will um, um, not enter into the cell, and repolarization will happen, and the resting membrane potential will come back down and become back to its set period of at negative 70. And we know that during repolarization, this is whenever it's becoming less negative. So depolarization is becoming more positive. Repolarization, it's becoming more negative, back down to the resting membrane potential. There's also something called hyperpolarization, which will become more negative than it previously was. So this is the neuronal action potential, and now we'll kind of work our way into discussing the cardiac action potential. So with the cardiac action potential, again, that's very similar to the neuronal action potential, with the exception of one thing. So you have an initial depolarization, right? This initial depolarization is going to be due to sodium ion channels, which I'll show you later on. Then there's something called the plateau, and the plateau is a little bit different than the neuronal action potential. There is no plateau period during the neuronal action potential. But during the plateau period, we'll discuss this later on, but this is followed by an initial repolarization. This occurs due to closure of those sodium channels that previously caused this depolarization. So I'll show you on this picture what's happening, and it should make a little bit more sense. So let's work our way down here to this picture. This is the picture I want you guys to be kind of familiar with. So this is the curve that you will see. The screen is showing you here an initial depolarization that is occurring. This rapid depolarization is occurring due to the influx of sodium, and that's important to know. So this opening of these fascated sodium channels is causing this resting membrane potential, which is around negative 95. It's causing it to become less negative and more positive, um, eventually causing depolarization or firing of that action potential. Once it gets here, this is an initial repolarization phase in which the sodium channels are closing. So because you have closure of this positive sodium channels, you are now becoming more negative, right? So you have opening of the potassium channels at this time as well. What I also want you to know is this plateau period. This is a plateau in which the potassium outflow is matched by a opening of the slow gated calcium channel. So there's really no change in the negativity of the membrane potential due to this potassium and calcium. So again, depolarization is going to be due to the opening of the fast gated sodium channels. Um, you're going to have initial repolarization right here. This is just going to be due to closure of these sodium channels. And the potassium channels are going to open in order to make the membrane potential more negative. But because you have these potassium channels that are open and potassium is flowing out of the cell, you have calcium channels that are coming open as well, making the membrane potential not change. This is why it's called a plateau. You're going to have repolarization. Repolarization again is due to this potassium outflow. Okay, potassium is continuing to outflow. Potassium channels stay open. However, the calcium channels close. This is leading us to repolarization. So again, we'll kind of walk through it on in terms of words. So depolarization, this is just due to contractile fibers having a stable resting membrane potential. Voltage-gated fast sodium channels open, sodium flows in. We talk about this initial repolarization. There's deactivation of the sodium inflow. This plateau, this is a period of maintained depolarization. Again, the resting membrane potential is not changing. This is due in part to opening of the voltage-gated slow calcium channels, right? Depolarization sustained due to voltage-gated calcium channels balancing calcium inflow, potassium outflow. So if I ask you which of the following ions are responsible for depolarization, you would tell me the sodium channels. If I said what ions are present during the plateau period, you would say calcium and potassium, right? And if I ask you what ion was possibly, or what ion was responsible for repolarization, you would tell me that it's the potassium channels. Because again, we have outflow due to the potassium. It's restoring the negative resting membrane potential. There's also called refractory period. And again, this is the same thing with neuronal activity. As you have an action potential, there is a period of time that must be maintained before you can have another action potential. So this is the time interval during which a second contraction cannot be triggered. Again, if you go through this in PowerPoint mode, you'll be able to see the actual action potential. This is a picture that I previously just showed you guys. Now we'll begin talking about electrocardiograms. So, as I previously discussed to you, I told you how the conduction system works, saying that it goes through the SA node into the AV node, through the bundle of His, branching off into the left and right bundles, and then eventually um, um, into the Purkinje fibers being responsible for ventricular contraction. We know that the SA node is responsible for atrial contraction. So this conduction system, as it begins to spread throughout the myocardium, we have um, an electrocardiogram, which we can see how is the heart conducting, and these different waves correspond to different levels of that conduction system. So we'll go through this. But just to read the text, the composite record of action potential is produced by all the heart muscle fibers. You can compare the tracings from different leads with one another and with normal records. There's three recognizable waves, and we'll learn the waves. We won't worry about the segments and the intervals right now, but the recognizable waves are the P wave, the QRS, and the T wave, and those will be important for you to know and what they respond to. Systole means contraction, and diastole means relaxation. Okay, so during firing of the SA node, you have recognizable P wave action. So as the SA node begins to fire, it will show you the P wave. So as the action potentials going from the SA node, you'll see as it reaches the SA node, you'll have atrial contraction, which is the P wave. Okay, you have something called the PR interval, and again, as the wave makes its way down through the AV node, right, to the left and right bundles. Eventually, we're going to reach the ventricles, and you're going to have, once you reach ventricular contraction, this is going to be QRS. So the ventricular contraction is going to be the QRS interval. What do I mean by QRS? This is the Q wave. This is initial downslope. This is the Q wave, and as it goes up here and reaches a peak, it's called an R wave. Okay, and then it comes back down here to another slope. This is the S wave. This whole segment right here represents ventricular contraction. So again, the we have the electrical signal beginning in the SA node. It's making its way down to the AV node, right? And as it reaches eventually the ventricles, we're having ventricular contraction through the QRS interval. Okay. Um, Once we have ventricular contraction, we're going to have ventricular repolarization, and this is going to occur through the T wave. The T wave is going to represent ventricular repolarization. So, as you have contraction of the ventricles, ventricular systole. Um, Contraction is another term for that is systole. And then you also go through a period called diastole, right? Relaxation of the ventricle so it can fill with blood. But repolarization of these ventricular fibers occurs through the T wave. This is a picture here that I encourage you to look at. This is a great representation. Depolarization of the atrial contractile fibers produces the P wave. So this is the initial upslope. Atrial contraction is, again, continuing to occur here. Depolarization of the ventricles, right? The ventricles are contracting. You have initial downslope followed by an upslope followed by another downslope. So you have a QRS complex. And this ventricular systole, this is during the period of ventricular contractions. And eventually you're going to have relaxation of that ventricle, right, into ventricular diastole where the blood is actually filling the ventricle. And this is the T wave, right? Ventricular relaxation. So I know this is all of this may seem foreign to you guys, and that's completely okay. But I encourage you to study this, become familiar with it, because again, this will be important, especially if you guys are going to go on to professional school, nursing school, or things like that. You'll be asked to attain EKGs. It's important to be able to look at them and see if they're abnormal, things like that. So, but it's important to understand normal before you can understand abnormal. We'll briefly talk about the cardiac cycle. All the events associated with the cardiac cycle occur during one heartbeat. You're going to both have systole and diastole of the atria and the ventricles. What is systole? Systole is just contraction. Diastole is just relaxation. So we know that during ventricular systole, the atria are relaxed. So therefore, they're an atrial diastole, right? The atria are filling with blood as the ventricles are contracting. Blood is being forced from high pressures to low pressures. This makes sense as the blood comes from the lower pressured atria into the higher pressured ventricles that will then be pushed into the higher pressured aorta. During the relaxation period, both atria and ventricles are relaxed. Okay, the faster the heart beats, the shorter the relaxation period. So if you have a very high heart rate, around 110, 120, why can that become problematic? It's because the heart doesn't have enough time to fill with blood and therefore can become ischemic, meaning that there's not enough oxygen present in the heart. This is just going over heart sounds. This auscultation is just another word for listening to the heart sounds. There's an S1 and S2 period, which you have closure of certain valves. We won't get into that. I don't think that's really important for our purposes. This is areas where you can listen to different closures of the valves. The left second intercostal space right here will be the aortic valve, and the mitral valve will be down here about the left fifth intercostal space. I'll kind of show you guys this in lecture. What is important is for you guys to know this formula. So we're going to talk about the cardiac output. And to understand the formula, you just need to understand what cardiac output is. Cardiac output is the volume of blood ejected from the left or right ventricle into the aorta or pulmonary trunk each minute. So in order to determine cardiac output, the amount of blood that is pushed out of the heart, you need two things: stroke volume, right, and heart rate. So stroke volume times heart rate. If you have the heart rate, you have that cardiac output, you can figure out the stroke volume, how much blood is ejected from the ventricle itself. The cardiac reserve is the difference between the maximum cardiac output and the cardiac output at rest. And it says here the average cardiac reserve is 4 to 5 times the resting value. So what determines the stroke volume? This is another important slide. So the preload, this is how much blood is being brought back to the heart. This is also synonymous with end diastolic volume, right? And contractility. How much does the heart contract? And there's different ionotropic agents. This is another term for um, contractility. There's different things that can make the heart contract at different rates. And afterload. Afterload is synonymous with how much pressure is being uh, how much pressure is downstream from the heart. So, for example, are the blood vessels clamped down? Do we have really high blood pressure, which is causing a strain, uh, uh, preventing us from pumping a lot of blood out of the heart? So, preload, what is preload? This is the degree of stretch on the heart before it contracts. Again, this is synonymous to the end diastolic volume. What do I mean by end diastolic volume? So, think about diastole. Diastole is the relaxation period in which blood fills the heart. So, end diastolic volume is the amount of blood left in the heart before it contracts. So, it's important to know here preload is proportional to the end diastolic volume. The more the heart fills with blood during diastole, the greater the force of contraction during systole. It makes sense that the heart can pump more if it has more in the ventricle. If there's more in the left ventricle, then the heart will be able to pump more. If there's not as much end diastolic volume, the heart can't pump as much. Kind of makes sense. So two factors determine the end diastolic volume: the duration of ventricular diastole. And I'm just going to go ahead and tell you now that, again, if you remember what affected ventricular diastole, an increase in heart rate. If the heart is constantly beating, then there's not enough relaxation for the heart to fill. Venous return, the volume of blood returning to the right ventricle. So these are two things that factor or that determine end diastolic volume. So what affects contractility? So we talked about inotropes. So inotropic agents, that word is synonymous with contractility. So positive contractility agents. Things like epinephrine and norepinephrine. Um, you guys can remember back to Anatomy and Physiology 1, and remember that during the fight or flight response from the sympathetic nervous system, you release hormones from the adrenal medulla known as epinephrine and norepinephrine. These are called catecholamines. Well, you have receptors that are present on the SA node, which are responsible for increasing the amount of depolarization that comes through the SA node, which will lead to an increase in contractility. This often promotes calcium inflow during the cardiac action potential. Do you remember what phase that occurs in? Right, the plateau phase, right? During the plateau phase, you have opening of those potassium channels, and then you have an influx of calcium. It's due to these positive ionotropic agents, which cause this increase in the influx of calcium during the plateau phase, which causes this increase in cardiac contractility. So you also have negative ionotropic agents, and these make sense. There's anesthetics. Again, you want the heart rate to slow. This is why some prescription pain pills and some type of opiates and benzodiazepines, this is why they can cause a decrease in the amount of heart rate. Anoxia, not having enough oxygen, acidosis, as well as an increased potassium in the interstitial fluid. So an increase in potassium in the interstitial fluid means it's low on the outside, right? So this would be hypokalemia. Hypokalemia can cause a decrease in the amount of heart rate. This makes sense if you think about it in terms of the cardiac action potential. Afterload, again, we said that this is the amount of pressure downstream. So this is the pressure that must be overcome before the valves can open. Okay, so remember we talked about how the ventricular pressure must be greater than the aortic pressure in order for the aortic valve and the pulmonary valve to open. Well, if you have an increase in aortic pressure, right, this is going to be problematic because the ventricles aren't going to be able to contract as well. So this is how we talked about afterload being able to affect the amount of blood that is ejected from the heart. So the increase in afterload causes stroke volume to decrease. We know that this would make sense, right? As we talked about the ventricular and aortic pressure gradient. Hypertension and atherosclerosis lead to increased afterload. For your purposes, I would like for you to know the definition of afterload. I would like for you to know its implications for stroke volume, how it causes a decrease in the amount of stroke volume. I'd also like for you to know that hypertension can cause an increase in afterload. So again, regulation of the heartbeat. We know that cardiac output is equal to stroke volume times the heart rate, right? Adjustments in heart rate are important in short-term control of cardiac output. So if you increase the heart rate, you increase the cardiac output. Think about that equation. This is a positive correlation. For example, if you decrease the stroke volume, how could your body compensate? By increasing the heart rate, right? This occurs oftentimes in patients that are undergoing shock. You have a decrease in stroke volume. Why? Because they're maybe losing blood, for example. This could occur through maybe a patient has a big bleed, so they're not able to return as much blood to the heart because they can't return as much blood to the heart. They have a decrease in the end diastolic volume. Because they have a decrease in the end diastolic volume, there's not as much stroke volume, right? They can't pump what they don't have. So how does the body compensate in order to increase the cardiac output? It increases the heart rate. So autonomic nervous system, epinephrine, norepinephrine are very important. So this is why during times such as shock, your body will increase the heart rate through secretion of epinephrine, norepinephrine. Again, it'll bind to this SA node. This SA node will trigger an increase in heart rate. It'll cause an increase in the influx of calcium. Calcium is responsible for the contractility of the heart present at the plateau phase. So autonomic regulation, I want you to know this. I want you to know these two. Norepinephrine has two separate effects. In the SA and the AV node, it speeds the rate of spontaneous depolarization. Again, I just told you that. It's released from the adrenal medulla. If you can remember back to our hormone lecture on hypothalamic pituitary axis, we talked about other endocrine glands. And again, we talked about the adrenal gland. The adrenal gland had two separate places. Do you remember the adrenal cortex, what it releases? Remember salt, sugar, sex. We talked about aldosterone, cortisol, and sex steroids. Remember what the adrenal medulla secretes? That's right, norepinephrine, epinephrine. Well, norepinephrine has an effect on heart rate, right? It has receptors. If you guys can remember back from your autonomics lecture in Anatomy and Physiology 1, there was the presence of alpha-1 receptors, which are going to be present on the blood vessels, and beta-1 receptors are going to be present on the SA and the AV node. Well, norepinephrine will have an effect on these beta-1 receptors present on the SA and AV node. This is going to cause spontaneous depolarization. In response to this spontaneous depolarization, you'll cause an increase in sodium influx. This sodium is going to cause a depolarization, but because you'll go through this plateau phase, right, during the cardiac action potential, this calcium that enters in, calcium is responsible for contraction. Again, calcium, it's this calcium entry which is responsible for the increase in contractility. Likewise, parasympathetic nerves release acetylcholine, which decreases the heart rate, right? So I want you to know these two. Norepinephrine causes an increase in depolarization, which increases the heart rate. Parasympathetic fibers release acetylcholine, which causes a decrease in heart rate by slowing the heart rate through depolarization. So there's input to the cardiovascular system. This is a very good slide to kind of just depict what we've already talked about. Input to the cardiovascular system from higher brain centers such as the cerebral cortex, limbic system, hypothalamus. The limbic system, this can trigger fear. This fear input, again, goes in through here, through the hippocampus on down to the cardiovascular center present in the adrenal medulla. Again, from here, you'll have input to the heart. So this will cause a depolarization in the SA and AV node, which will increase the heart rate. Again, this is going to be an important slide, chemical regulation of heart rate, hormones, and cations. We talked about relative concentrations of potassium, calcium, and sodium being important. Sodium and calcium are primarily going to be responsible for depolarization during the cardiac action potential, and then we know that potassium is responsible for that repolarization. So I'd like for you to know those two things. Thyroid hormones can also increase heart rate and contractility. We talked about this on patients with hyperthyroidism. Remember when they produce too much thyroid hormone? Well, thyroid hormone such as T3 and T4, primarily going to be T3, can cause an increase in the heart rate by binding to beta 1 receptors present on the SA and AV node. We know that this will trigger spontaneous depolarization of the SA and AV node, which will then make its way down to the ventricles and undergo ventricular contraction. Also, epinephrine and norepinephrine, like we previously just discussed. So, again, this is just a brief overview. We're going to cover this more in lecture. I hope this has been helpful. Again, I will host a review session after we finish the respiratory lecture, and we will cover anything that you may not have a good understanding on. So, please feel free to reach out to me. Again, I thank you guys for your time and your patience.